But also, we should know that lots of times there is no choice other than extracting implants, because when you have some kind of situations where bone loss is in such a degree that you can do anything about it, and also soft tissues, you will have to extract implants, and this will cause severe defects that will lead to significant grafts. Well, what's your first choice in grafting and biomaterials? I can tell you what was mine. Mine was block grafts and xenografts of bovine origin, mainly that. But the thing with bovine is that they don't stimulate bone formation. They are just and only osteoconductive. So when I came across this calcium phosphosilicate material in this human study and other studies, I was stunned, because despite it was an alloplastic graft, in biopsies you had like double a vital bone of when you on those biopsies when compared to an organic bovine bone. Well, and this is because it's a Class A bioglass. It's been used for long in orthopedics for 30 years now. Go figure. So, and it's classified by the FDA as an osteostimulator. It stimulates bone formation. I mean, the healing timeline, the bioactive healing timeline of this biomaterial is really, really awesome. And on 4 days, you got a lot of differentiation. You have some mineralization. So it's really interesting to see the biology of this biomaterial. So in this clinical case that I have shown you before, where we have this implants, and we can also have the choice of extracting or keep the implants, but we can see that in this case, well, no soft tissues will fix this. So implants have to be extracted, and bone graft is absolutely needed. The question here is this material, this calcium phosphosilicate, suitable? Because future implants will be placed mostly in regenerated bone. What can we do? What kind of options in terms of bone grafting do we have? We have autologous and non-autologous, okay? So autologous is said to be the gold standard in what comes to 3D bone grafting and severe defects. We'll see a little bit about that a couple minutes later. But you can still use allografts or xenografts, and a lot of people are using both. But you can go alloplastic, okay? Because that's what calcium phosphosilicate is. It's an alloplast. Alloplast means it's from a synthetic or natural origin, but it has the capacity of transforming itself into native. So let's see. Gold standard is said, for many authors, is said to be bone blocks. Let's see the literature, a little bit of the literature on vertical bone augmentation. Because when we go through several articles, and this is one of the most interesting because it's a systematic review and a meta-analysis from Mr. Urban, which is very potent in terms of scientific evidence. And what we can see is that all the options that we have, which are mainly three: distraction, osteogenesis, bone blocks, and GBR, all of them demonstrate significant bone gain when you use any of them, okay? But the thing is that with distraction osteogenesis, you will have almost 50% of complication. And with bone blocks, you will have close to 24% of complications. While with GBR, you will have close to 12% of complications, half of the complications that you can expect with bone blocks, meaning that you can augment a similar amount, because as you can see, the augmentation, the average augmentation with bone blocks and GBR is pretty much the same, but you cannot, if you're using GBR, you will incur in a lot less risks than if you use bone blocks. So all of them are feasible and effective, but complications are common. That's what you should expect. And the most suitable approach remains unclear. And if autologous blocks have been described as the gold standard for a lot of time, well, advances in the field of biomaterials have favored the use of less invasive approaches. And that is really quite something. Let's see what I did in this case. Well, as you can see, the implants were floating out of bone, and well, we had to pull them out. As you can see, huge bone loss. I did it in a very, very traumatic way so that I could preserve the most bone that I could. I had a customized tie mesh from Implantize. I had a customized tie mesh done according to the CBCT of the patient. Now I loaded it with the calcium phosphosilicate morsels and then filled the voids with putty. And now you can see that I covered the whole thing with a collagen membrane and a tension-free suture to close it all. And this is how you can find the severe posterior mandible defect 8 months post-op. At 8 months, I re-entered, okay, after 8 months. But I wanted to know what was there, what was beneath that, what was in that huge area of regeneration. It's been published in Compendium and also in Dentistry. Maurice Salama and we published this article, so you can see it in Compendium. And the thing is, I took 4 cylinders as I placed the implants on re-entry, and these were taken to analysis, to histological analysis. This was done with Coimbra's Medical School Hard Tissues Lab. They have a tremendously good lab to do all this histology. And the thing was very, very surprising because you could actually see a lot of areas with surrounding bone showing zones of less maturation, and this meaning that we would have there an active bone remodeling. So there's a lot of bone activity in there. You could also find osteoid in the surface, not only of the bioglass, but also on the bone surface. The biomaterial interface was being remodeled, completely integrated into the surrounding bone. And you could also see reversion lines. Well, this meaning that after all, it seems to be possible to grow bone with no bone. And this was proven by Molly Stevens several years ago. Okay, this is where this case stands nowadays. I got 4 implants already placed, almost ready to rehabilitation. And what you're looking at is the multi-unit abutments, the healing caps of the multi-unit abutments. So my implants are way beneath that. Well, let's see another case. This one I would say even more challenging in a way because it's a periodontal compromised patient. And this patient, she had an implant. That implant was failing because of a periimplantitis. And so what I did was taking the implant out, you can see a detail of the huge bone loss over there. So in this case, I went for a tent pole technique with tie mesh and a calcium phosphosilicate, and of course, a membrane, a collagen membrane. And after doing it, you can see that we achieved a very good rebuilding of the site. And again, 6 months after the guided bone regeneration, I decided to do a biopsy on reentry. And on reentry, I took a biopsy, a cylinder, and that cylinder, this will be published soon. That cylinder, with that cylinder, we did an histomorphometric analysis, and it was awesome because you could find new bone just after 6 months. New bone was there, like it was 55%, and only 20% of particles of the calcium phosphosilicate particles. So it was really awesome. And this would only histologically translate the beautiful clinical result at the end. Because as you can see, even if it is a periodontal patient, we ended a lot better than we were before. Because before you had lining alveolar mucosa almost to the implant. Here, and without addressing that problem in particular, what he gained was even some keratinized mucosa, and he could reach this beautiful emergence profile despite it's a periodontal patient, one of the most difficult patients to treat in our current clinical practice. So grow bone with no bone seems to be possible after all.